mental health is concerned. So today we want to hear from him as far as the issue of mental health, the mental health impact of COVID-19. I'm sure we are going to learn a lot from him. Now, I also have to thank the second speaker, Dr. Nusirat Elelu, who's going to share her experience as far as surveillance, COVID-19 surveillance in northern Nigeria is concerned. We are deeply grateful. We actually a lot tried, I think we wanted to feature her last month or so. Unfortunately, we could not make it. We are very grateful that this month she's able to have time to be with us this afternoon. We are extremely grateful. To all the attendees, we are very grateful for joining us. I'm sure you are going to learn a lot. This is like what the moderator said, one of the series of webinars that we are organizing for COVID-19. Our aim is to contribute to multifaceted response strategy against COVID-19. Even though some will say COVID-19 has substantially gone down, but so many things surrounding COVID-19 is still with us. And that is why we want to sustain this effort to see how the academy will make a serious contribution to mitigating the impact of COVID-19 within the country. And we want to do it from so many perspectives, as we have shown earlier. So with this, I want to all welcome the attendees, for them to have time to be with us this afternoon. Thank you so much, and I'm sure we are going to enjoy this session. On behalf of the Academy, I welcome everyone to this webinar. Thank you.
Thank you very much, Dr. Ibrahim. Well, today we are here to hear the views of the panelists on the impact of COVID-19 pandemic on mental health of the populace, as well as the lessons from issues that surrounds the pandemic with focus on northern Nigeria. Each panelist will have 20 minutes to speak, and without further ado, I would like to introduce Dr. Olayinka Atilola, who is currently an associate professor of psychiatry affiliated with the Department of Behavioural Medicine, Lagos State University. He holds a bachelor's degree in medicine and surgery. He is also trained in the field of psychiatry with specialization in child and adolescent mental health. He holds the fellowships of the Medical College of Psychiatrists of Nigeria and the West Africa College of Physicians, being the highest academic and professional certifications in clinical medicine in the region. Dr. Atilola is widely published with over 75 peer-reviewed academic publications to his credit. At least 3 of his publications are in the Lancet Journal series, rated in the top 1% of global academic journals in medicine. His main area of research interest is child and adolescent psychiatric research. Dr. Atilola is a young physician leader of the World Academy of Science, co-founder International Child Mental Health Study Group, and a fellow of Nigerian Young Academy. Dr. Atilola, thank you for joining us today, and the floor is yours. Thank you.
Yeah, thank you very much, Dr. Nusirat Ibrahim, for the humbling citation. Without wasting much of our time, and with the hope that electronic gadgets will not give us problems, I will be sharing my screen and I will be proceeding with this topic. So far, I've been able to share my screen. I hope we can see it.
Yes, sir, we can see it.
Yes, we can see. Go ahead.
Okay. And obviously, I don't need to ask whether I am audible, in the sense that you obviously can hear me. Okay. Today, I will be talking about a topic which is one of the trending topics in the field of mental health in the last 2 years, which is the mental health impact of COVID-19 pandemic. And the synopsis of my discussion will be in this form, as I'm trying to go to the next slide, but I don't know why. Okay, the synopsis will be in the form of the burden of COVID-19, and I will be discussing the fears and the anxieties, as well as the disruptive social changes that was occasioned by the pandemic. And I will be talking about the mental health outcomes of all these fears, anxieties, and disruptive social changes. And then I will be rounding up with some lessons and way forward. As we are all aware, the slide that I'm currently sharing are things that there was a time when this kind of picture dominated our life in the world, including in Nigeria, where we are reading COVID-19 updates, how many people are dead, how many people are infected. I mean, I'm sure we can all remember, this was the last of them that I saved on my laptop. I think this was dated the 25th of August, 2020. And despite the horribly unreliable data that we have in Nigeria, as at that time, more than 52,000 cases has been confirmed, with more than 1,000 already dead. So it was a big deal. Maybe not as big as it is now, but it was a big deal then. And what was the burden? We know that one of the burdens of the COVID-19 pandemic is that the COVID-19 infection was a very rapidly spreading infection. It was associated with mortality, even when that has slowed down, say in the last 6 months, thankfully. As at the last 24 hours, a whooping 527 million cases have been confirmed worldwide, with at least 6.28 million deaths worldwide. That is a whole number of deaths related to any condition within the last how many years. In Nigeria, like I said, the data is unreliable, but from the WHO website, about 256,000 cases have been confirmed in Nigeria, and more than 3,000 people have died. I can assure you that this is a gross underreporting because of our unreliable data. But of course, that is not the discussion for today. The discussion for today is how the COVID-19 pandemic impacted on our mental health. This singular slide will summarize everything I will be discussing, and I will be making a lot of reference to it. And what this slide is showing is what is the pathway from pandemic to mental health problem. Don't forget, the topic is mental health impact of COVID-19. But of course, the COVID-19 pandemic is one entity. Mental health impact is another entity, but there is a pathway that links them together. So the pandemic was associated with certain fears and anxieties, as well as disruptive social changes, which I will be elaborating later. These fears, anxieties, and disruptive social changes resulted into or constituted themselves into a mental health risk. There is difference between mental health risk and mental health problem. Mental health risk is something happening to you that puts you at risk of developing a mental health problem, while mental health problem is the mental health problem that you develop. So the pathway is that the pandemic was happening. The pandemic was associated with certain fears, anxieties, and disruptive social changes in our life. These fears, anxieties, and disruptive social changes constituted a mental health risk, which now led to mental health problems. So beyond this slide, let me now try to break it down. What were these fears? COVID-19 was associated with palpable fears. That is not a doubt. And these fears were associated with the high infectivity of the virus. Everybody was hearing about the fact that the virus was spreading like wildfire. And it was also associated with high mortality. People were hearing that people were dying. And also in the middle of that, for once, we had a pandemic in the middle of a time when the social media has reached its crescendo. And then that led to a fast-paced transmission of information. If one person got infected in Oyo State, the information will reach you. If another person gets infected somewhere in Minnesota, the information will reach you. And there was this high level of transmission of information, which was at one point described as an infodemic, in which the information was just pouring to our phones and fueling our fears. And then enter the conspiracy theories around COVID-19. There were so many conspiracy theories, rumors of COVID-19 pandemic being the Antichrist, rumor of New World Order, that this is a New World Order being set. This is 5G network that they are using that is causing COVID-19. COVID-19 is signaling the end of the world. These are information that was getting to our table. And for the uninformed, fears were being built in the mind of people. Don't forget, I told you that these are what constituted the mental health risk. Living in fear is a mental health risk. And COVID-19 infodemic created a fear for us. And of course, this was propagated by people that we have a lot of respect for, people that are highly placed, like highly placed politicians, propagated some of the conspiracy theories. A good case in point is Donald Trump was propagating some of these theories. Scientists were propagating it, especially those that are in the business of pseudoscience, as well as clergymen. And in the middle of this, a lot of people develop a high level of fear. And of course, there were, beyond fears, there were real anxieties. These are the mental health risks that constitute the pathway to mental health problems as a result of the pandemic. So what are the anxieties? Uncertainties over exact nature of the pandemic. A lot of people didn't understand. So there was this fight between the conspiracy theorists and the scientists. And in the middle of that, people were confused, and that led to anxieties. People don't know how long it was going to last. They don't know who will die. They don't even know what was happening to some of their loved ones that are trapped elsewhere. You have families in Canada, families in America, families in Singapore, and the whole world was shouting about it. And then you don't know what is happening to them. And you don't know what will happen to your own personal economy, your property, your job. A lot of people were locked in their houses, and your property is somewhere on Lagos Island. You don't know what was happening to it. Your job, your business, your savings. And you don't know what else might go wrong. All these things built up a level of anxiety beyond the fears. And then beyond fears and anxieties, we had the lockdown and the associated disruptive social changes. What are disruptive social changes? Disruptive social changes are things that happen to you that change the way you know your world. Let's say your world is that you're a lecturer, you go to class, you teach your students, you go to school to pick your children, you return home, and then your husband comes to come and join you. That is your world. When that is disrupted, we call it a disruptive social change, and it is recognized as a major mental health risk. It is one of the pathways to mental health problem. Any time our routines change, and it changed disruptively, and COVID-19 and its lockdown came with a lot of disruptive social changes. What are these changes? Social isolation. People became a lot more isolated than they used to be. People couldn't have access to their workplaces. You don't know how much mental health support your workplace gives you until you can no longer access it. The fact that you go there in the morning, you meet somebody in the lab, you gist, you laugh, you discuss Nigeria economy, politics, you don't know how much impact those things are having in promoting your mental health until it is no longer there. Children no longer have access to their playground. They no longer have access to their school. Those are disruptive social changes. And people were not able to go to their social clubs, their joints, where they meet their friends, where they have a beer before they go home, and other recreation centers. All these things constituted disruptive social changes that changed people's lives. And then there was reduced physical activity. You may not know, but I'm telling you today that being physically active is a major mental health promotion. So during the lockdown, when we were not able to be physically active, it was constituting a mental health risk. And then there was a change in our sleep-wake cycle. One of the things that kept our mental health going is when you have a fairly regular sleep and wake time. But during lockdown, all this got disrupted. People were sleeping in the afternoon, they couldn't sleep at night, they were sleeping in the morning because the day was just running without boundaries anymore because you were all indoors. These were examples of some of the disruptive social changes that came with COVID-19 and that led to mental health risk. Others include dietary changes. The food we eat, the amala that you always like to buy on the way to your office was no longer available. And then people had an increase in consumption of social media, which in itself can constitute a mental health risk. And then people had difficulty adjusting to changes in their work structure. I personally had a lot of problems delivering online lectures to my students. I realized how much mental health promotion, the fact that I see their faces, we laugh together. You don't know what. Now I had to sit in front of a computer and speaking to the computer. I didn't even know whether anybody was listening to me. And it was more stressful. And after some time, people also developed what was later described as Zoom fatigue, in which when you are invited to a Zoom meeting, you just say, please, I'm done. I can't attend any Zoom meeting again because you are just sitting in front of a computer. And that is what you have done all day. It is completely different from sitting in front of a human person and having a human contact. And there was also an increased burden of childcare because children were no longer going to school. So the amount of work that mothers and fathers had to do increased. And I'm sure most people can relate with some of these things I'm talking about. And then there was reported increase in domestic violence because people live together, yes, marriage had their challenges, yes, but they don't spend more than 8 hours together. They go out. So people had opportunity to dissipate their irritability. But when they were locked together and they couldn't leave, they were in each other's faces. People were no longer able to have those things that they used to manage conflict, like just stepping out, go to a joint, go drink a beer or whatever. People were not able to do that anymore. And then the risk of domestic violence increased. And of course, with increased domestic violence is a mental health risk. And there was loss of job and loss of income. All these are disruptive social changes that constituted mental health risk. And then there were lived experiences beyond fiction. Lived experiences. During that time, people had to experience quarantine and the uncertainties that came with it. If you are ever quarantined, you will know what I'm talking about. When you are waiting, just a waiting game, are you going to be sick or not? That is not something that works with mental health. And of course, the experience of being infected, you are, okay, confirmed you have COVID-19, and the uncertainties. Am I going to be ill? Am I not going to be ill? And of course, people had to face the challenge of caring for an infected loved one. People had to take people to hospital. And of course, people had to handle the news of infection or even death of a loved one. People received a lot of news. People got information about somebody dying. And that's lived experiences. Those are lived experiences, and they constituted mental health risk as part of the COVID-19 experience. So all these things, like I said, the fears, the anxieties, and the disruptive social changes are the mental health risk that eventually led to mental health problems. What were the mental health problems that arose from the mental health risk occasioned by COVID-19? There was an increase in the prevalence of mental health problems worldwide. There is a worldwide data that showed that there was a 25% increase in the prevalence of mental health problems in the course of COVID-19 pandemic. And I can confirm that without using data. I work as a doctor and I run a mental health clinic. And I realized that, especially the one that was privately run, the volume of patients that were calling in for mental health complaint doubled and tripled. In fact, after some time, I became the center point in a private clinic where I used to be by the side clinic, because the urology clinic, the gastroenterology clinic were the big clinic. The psychiatry clinic was a small one, but it became the major one, while the other one became small during the pandemic. I can assure you of that. And of course, people that had existing mental health problems, people that were being managed maybe for depression, anxiety, or other problems, they started having exacerbation of their existing mental health problem that is already well managed. And so a lot of my patients that were stable became unstable during the pandemic. And of course, these disorders that we saw anxiety disorders, we saw depression, we saw sleep disorders. These were the common ones. Anxiety disorder was very common. Depression followed it. Then people with primary sleep disorders, they couldn't sleep. Their sleep cycle became all messed up. And then we had the worried well. This was the interesting ones. They are well, but they are worried. They keep telling you that they keep doing COVID-19 tests every other day. And they've got their nose blistered, just checking and checking. And you keep reassuring them that you are not infected. And they say, okay, thank you, doctor. Then tomorrow they are in the clinic again, wanting to do COVID-19. So we tag them the worried well. And that constituted a mental health diagnosis, because it is not a physical health diagnosis. And we saw all these things as part of the cumulative effect of the disruptive social changes, the fears, and the anxieties. That is where we found ourselves. And what were the other complications that arose? Now we were experiencing an uptick in the prevalence of mental health problems, and more people were breaking down. At the same time, there was disruption of the mental health service that they were coming to come and receive, because the pandemic came with disruption of our already poor mental health care system. For instance, there was shortage in mental health service providers as a number of personnel was deployed to COVID-19 response teams. Some of my own resident doctors who are supposed to be providing mental health services, the commissioner just came and said, we need doctors, whatever specialty, we don't care. And they took them to go and do COVID-19 response. While they were there, mental health service will not be able to render it because the personnel is not there. And then there was an increase in number of people that want care. Then some of the facilities were converted to isolation centers. So we have a clinic that used to be a mental health clinic, but because we needed isolation centers, we closed that down. That is service disruption in the middle of an uptick in prevalence. And then service contraction also happened due to social distancing requirement. So a clinic that used to accommodate 20 people, because of social distance, can only accommodate 5. So we now start having a very long backlog list because we can only take 5 at a time. In a clinic that we used to take 20 because of social distancing. And then some of the clinics were shut down abruptly because somebody got infected and we have to do fumigation. With this description I've given, you will not have a doubt in your mind that mental health service will be disrupted at a time when the need was highest. And this was a major challenge. And I give this last suit example. This is a data I copied from a paper that we published sometimes early last year, I think, or mid last year, in which we show the pattern of number of patients that we're seeing. If you see, starting from January 2019, we were seeing an average of about 350 to 400 patients per week. You can see it going up and down, but immediately we entered February 2020, you see that drop, that sharp drop, that dropped to 0 between April and May. And then by June, it started peaking, and it never got back to our pre-COVID-19 level until far in December 2020. This is a real-time data that we collected from our clinic, and we published in a journal trying to show evidence of disruption of service, that people were not able to access service like they used to. So this is a fact. So what are the lessons that we learned? We learned that Nigeria was unprepared for the mental health crisis that came, and will still come with a major pandemic. It's not only that we are not prepared now, we are still not prepared for another, because the ratio of mental health practitioners to population is still not only abysmal, but scandalously low. We have 1 psychiatrist per 1 million population in Nigeria. Meaning that as I am sitting down here, I have a burden responsible for 1 million people. Because based on our population, the total number of psychiatrists practicing in Nigeria amounts to this ratio. If we bring in clinical psychologists, bring in nurses, the ratio is even more abysmal. And because of that, we think that one of the way forward is that we need to improve population mental health literacy, which is very poor in Nigeria. People don't understand mental health in Nigeria. It's so bad. And that if we educate people, they will be able to understand self-help strategies. In a setting where you don't have practitioners, you need people to have self-help strategies. They need to understand their mental health and what to do. And so an investment in mass public mental health literacy will be a major way forward for Nigeria. And there is also a need to expand telepsychiatry services because of the lockdown. I'm sitting there at home now. I can as well be having a consultation with you. And we wrote a proposal for expanding telepsychiatry services in last week. And we are still hoping that we will get funding for it as a complementary service to physical clinics. And of course, we also talk about things like step care approaches to addressing uncomplicated common mental health problem. In a setting where you have 1 psychiatrist for 1 million, you have to step down the care. You have to create a middle level practitioner. So we are thinking about, let's say, a psychiatric nurse or a psychiatric social worker, that we can train them on how to render basic mental health services, which is what majority of people need anyway. Very few people actually need specialist care. But we don't have this well-developed, well-regulated, middle-level step care approach in Nigeria. And I think that is one of the things that we can develop. I have only 20 minutes. I probably think I've overshot it by a few minutes or so, but you've been a very wonderful audience, and I thank you.
Thank you very much, Dr. Atilola. That was an insightful presentation, and I'm sure the audience would have questions, but we will leave the questions to be answered at the end. So let's go then to the next speaker, Dr. Nusirat Elelu. Dr. Elelu is a distinction graduate of veterinary medicine from University of Maiduguri with a Master's of Public Health from University of Ibadan and PhD measuring epidemiology from University of Bristol, United Kingdom. She spent a summer at Institute of Tropical Medicine, Portugal, where she underwent molecular-based training, and she is a recipient of the prestigious African Research Excellence Fellowship that supported her postgraduate training at the University of East London, UK. In the year 2021, Dr. Elelu became board certified by the College of Veterinary Surgeons of Nigeria as a Fellow of Public Health Specialty. She was also last year selected as affiliate of the Africa Academy of Science and an appointed member of the African Research Excellence Fund College of Experts to groom the next set of African researchers. Dr. Nusirat Elelu is currently an associate professor of veterinary public health at University of Ilorin. She has supervised several undergraduate and postgraduate students, as well as several publications in high-ranking international journals. She teaches veterinary public health and dedicates her research to infectious diseases, vector-borne zoonosis, that is, diseases that can be communicated from animals to humans, and One Health. Dr. Elelu has attended several national and international conferences across several continents of the world to catalyze lasting research collaboration. She is a seasoned administrator and has held several academic positions including head of department, veterinary public health, and faculty postgraduate coordinator. She's also currently the executive secretary of the Kwara State Primary Health Care Development Agency, which champions the implementation of priority primary health care policies and drive quality and equitable healthcare service delivery at the grassroots in Kwara State. One of our core mandates at the Primary Healthcare Agency is also the vaccination drive against vaccine preventable childhood illnesses, as well as vaccination against COVID-19 disease. In her contribution to community development, she chaired the COVID-19 Community Engagement Committee in Kwara State that ensured the grassroots population were sensitized to uptake preventive measures against the COVID-19 pandemic. Dr. Elelu, thank you for joining us, and the floor is yours for your presentation. Thank you. You're welcome, ma'am.
Thank you so much, Dr. Nusirat, for that brilliant citation. I'm really thrilled that the Nigerian Young Academy has found me worthy to join this seminar series. Good morning, everyone. I'd also like to especially greet the previous speaker, Dr. Atilola, for that very eye-opening presentation. Of course, mental health issues are not really taken seriously, especially where we come from around here. So it's good to know that your team are working on how to bring that to the fore and to help people that might have been affected one way or the other with the ongoing pandemic as it is. So I'm going to try and start my presentation by excuse me. Hello.
We are with you.
Can you see my screen now?
Okay. Yes, ma'am, we can see, but can we put it on slideshow?
Okay, I'll do that right away.
Okay.
Can you see it?
Yes, but you put it on presenter view. I think slideshow would be better.
Let's see. Slideshow. Okay.
Yes.
Do we have it on slideshow?
Yes, I think it's better now.
Thank you very much. So good morning once again, everyone. So I got 20 minutes, so I should end by 1. So I'll try to keep to time. So my topic for discussion today, I will be looking at the lessons surrounding COVID-19 pandemic in northern Nigeria, especially the animal surveillance as a future preventive strategy. So this is my outline. I would try to not talk about introductory bits, and then of course, a little bit about the pandemic in the country, lessons from northern Nigeria, and what we need to do in regards to issues surrounding the pandemic, as well as current preventive strategies. I will also go into the animal surveillance bits, as well as the future perspective, then I can take questions from my audience. So coronavirus, like we know, I don't think there is any virus that is heavily studied at this time more than the coronavirus. I'm sure without even writing any much about here, merely by putting this, spiked spherical envelope picture over here, we would immediately know that this is the coronavirus that has brought the world to its knees in the last 2 years, 2 years plus now. So we would, I would also like to inform us briefly that, of course, we have different genera of the coronavirus, which are the alpha coronavirus, the beta coronavirus, the gamma coronavirus, and the delta coronavirus, which have been identified as coronaviruses of concerns for public health concern in the world. So we would also know, I would talk too much about the pandemic, or just say briefly. I know that Dr. Atilola has said a bit about some of these indices about the COVID-19 pandemic. So just briefly, the most recent member of the coronavirus species, the SARS-CoV-2, we will recall that in 2002, the Middle East respiratory virus, and the recent one in 2019 is the SARS-CoV-2, which is the causative agent of COVID-19 pandemic. This was first reported in China, specifically in a seafood market in Wuhan. And we know that the Chinese have an open, culinary habits because they believe in the health impact or health importance of eating wild animals and stuff like that. So it is a very popular market, and that was where COVID-19 pandemic was first recorded in 2019. So we know that COVID-19 can also be transmitted mostly through the respiratory sorry. Can you see me now?
Yes, we can see you.
Okay, excellent. I thought that was on. Okay, so the respiratory droplets such as moisture, aerosol, the mucus from the respiratory are all sources of COVID-19. We also have the lacrimal droplets. And of course, because we know that COVID-19 also has the possibility of fecal-oral route due to the enteric clinical symptoms of COVID-19. Other clinical symptoms will include common cold, which mimics other common influenza viruses. Of course, we also have the hepatic and the neurological symptoms of the disease. So according to the WHO dashboard, as of 25th of May, globally, about 523 million people have been confirmed to have had COVID-19 disease, of which over 6 million deaths have been reported worldwide. And we know the attendant economic effects of the COVID-19 on the global economy. Closer home, we also have that over 26 million people, so we talk about now the vaccination drive, that while we have over 11 billion vaccines have been administered as of 23rd, 26 million Nigerians have also been vaccinated so far, which is about 23% of the country's population, which is way below where we want to be. I'll talk further about that when I get to the preventive strategies. So what are the animal hosts for coronaviruses? They are very diverse. Coronaviruses are really diverse, as they can infect quite a number of not just domestic but wild animals. And of course, we know that they can cause major zoonotic outbreaks. As you can see, the number of humans that have so far been confirmed positive from the disease. And in the last 2 decades, we have 3 novel beta coronaviruses, like I've said earlier, that have originated from bats. The reason why I'm talking about the animal hosts is because I need to provide an insight, a background insight about the topic of discussion, my topic of discussion for the day. And we need to understand that coronaviruses, like other zoonotic diseases, also have an animal origin, of which the fruit bats have been, where they have originated from the fruit bat and have jumped to the human by way of the intermediate vertebrate host, who's, that fuel the outbreak. Just like we have the SARS coronavirus in 2002 with civet cats, we also have the Middle East respiratory virus as dromedary camels serving as intermediate vertebrate host for the COVID, for the Middle East curve. So we now have the 2019 SARS-CoV-2, which has also brought the world to its knees. So what are those specific animals that have been incriminated as vectors of SARS-CoV-2 or other coronaviruses? We have the bats and birds, which are the popular precursors or reservoir of coronaviruses. So bats are specifically for alpha coronaviruses and beta coronaviruses, while the birds fuel the gamma coronavirus and the delta coronaviruses, through evolution and dissemination, obviously. So the companion animals are also very susceptible to SARS-CoV-2, with several studies documented for cats being highly susceptible, and of course, even having the potential to transmit the illness to other naive cats. Dogs are less susceptible, but studies have shown that they have also been tested positive for SARS-CoV-2. So the first COVID-19 case was in companion animal, was reported in the Pomeranian dog in Hong Kong, in China, and of course later in cats. So we can see that our companion animals are really susceptible to the SARS-CoV-2, because studies have proven that people can actually give companion animals the SARS-CoV-2, and it can also run full cycle by reciprocal infection back to humans. So that is why there's really need to draw attention to those groups of animals. We also have livestock animals that are also susceptible to coronaviruses, especially the pigs. Pig cells have been found to be infectable with coronaviruses. However, they are really resistant, although they can infect, but they are resistant to the to infection with the virus, which is thankfully. So what that means is that for now we can't see, we don't have evidence that coronaviruses can actually be transmitted from pigs to other pigs or to the other animals or to humans, but they are heavily susceptible to it, but are resistant. So other wild animals, of course, we know that tigers, it was all over the papers that we had the Malayan tiger, Emir tiger, and the African lions were susceptible to COVID-19. And the worrisome one were the minks, which are also susceptible to SARS-CoV-2, because we not only have minks from the zoo, but also minks from mink market, from mink farms were heavily susceptible to COVID-19. So we have other wild animals like pangolins, African green monkeys, rhesus macaques, pumas, and snow leopards that are zoo animals have also been found to be susceptible to SARS-CoV-2. So on the laboratory front, we also have the golden Syrian hamsters that have been confirmed to also be susceptible in recent laboratory experiments. So the dashboard for Nigeria is what we have here. So far, this is just mimics what Dr. Atilola has presented, but I'll just talk about the total number of vaccinees that we have about as at 22nd of May, 2022, we have about 23% of Nigerians being vaccinated, which is way below the number of people that we expect to vaccinate. So what are the current preventive strategies? For any pandemic of this nature, of course, the world was hit with the suddenness of such a pandemic, and we needed to quickly institute some national level policies, instituting specific protocols like the use of personal protective equipment, mass testing, as well as the unpopular lockdown policy. In public health, we public health practitioners didn't really have a choice with the lockdown policies because we had to trade off between having people exposed to a virus we didn't know much about, and outrightly grounding the economic situation of the whole world at that time. So we also had other national policies like population level and general population policies, such as the rapid response. You would see rapid response teams that was all about for case isolation, case identification, contact tracing, and even environmental disinfection. These were all common occurrences around the heat of the COVID-19 outbreak. Of course, vaccination, the arrival of vaccines and new therapeutics really came to events because vaccines are very efficacious in preventing infectious disease. And obviously, discovery of an effective COVID-19 vaccine was one of the highlights of the COVID-19 pandemic. And now we have about 4 different antigens, AstraZeneca, Pfizer, Moderna, and the single-dose Johnson & Johnson vaccine that are now available in country and in other places globally. So what are the other preventive strategies that we need to put in place? Which this is research. We must, because this is a new virus, we must continue to study the viral evolution, and we need to explore ways that they interact with the human, because during the early development, we must have different conditions of immunity, and we must understand how this pans out in the human system. So this will help us to understand the pandemic and, of course, institute proper preventive strategies and management strategies, of course. The mass surveillance is also very key. We need to continually carry out mass surveillance in the human and animal disease so that we can promptly promptly detect SARS-CoV-2. So I will draw more about mass surveillance in my subsequent. So what are the issues surrounding COVID-19 pandemic in northern Nigeria? There is a lot of disbelief in the existence of a pandemic. And I cannot but agree with the previous speaker, where people began to talk about Antichrist, and so all sorts of disinformation, infodemics, and misinformation out there, where people even thought it was a plot of the government to restrict the people and etc. And that gave, we lost a lot of time. We lost a lot of time in the control of the COVID vaccine pandemic at that time, because we needed to first of all convince people about the existence of the pandemic. We also had reluctance to abide by the COVID-19 safety protocols, because of the disbelief in the existence of the pandemic. So it was a huge task for people to adhere by the lockdown policy. We had to institute not just the lockdown, but of course enforcement of those lockdown policies across the state, across the country, across even globally. Of course, people also didn't want to use their personal protective equipment. And of course, if you are a Nigerian, you will agree with me that during lockdown, the lack of partying was, due to the restriction of social distancing, was also something that affected, our response to COVID-19 pandemic. And then I have to also talk about the public health response system, because this is the developing country problem. Our health system itself is weak, and of course, if we're not able to manage endemic, diseases, imagine having a pandemic like COVID hitting our already very fragile health system. So that we had a health system that was poorly, ready to handle a pandemic of this nature. Of course, inadequate testing. So, we needed to test, because you needed to separate who had the virus away from those who didn't have the virus. So there was need for us to carry out mass testing. So there was, some we had very few testing capacity in the country. We had delays in getting results. We had delays in testing sample collection. Ask Mr. Animasha. Okay, so we had a very poor testing capacity in the country, and that's really affected our ability to detect promptly the people that were positive from those that were not positive, and you could see that once there was an improved testing capacity, people were, were able to be detected and were able to control and break transmission of the virus. Then vaccine hesitancy. Despite the fact that vaccination is one of the most successful public health intervention of all time, we had hesitancy from uptake of COVID-19. On the frontline agency for administering COVID-19 vaccine we had an uphill task of people accepting that COVID-19 vaccine was efficient, and because of this hesitancy, we had people believing that they were going to change DNA structure of people that had been vaccinated. So, of course, people had to wait to see what happened. I personally had to, publicly take the COVID-19 vaccine alongside people that were stakeholders in the country for people to believe. And of course, they had to wait to see if I was going to die from taking the COVID vaccines before people came out and there was trust in people, by people to take the vaccines. So how do we change the narrative through the animal disease surveillance? Because we have seen that COVID-19 has joined the ranks of other zoonotic pathogens, and we have to see how we in the animal health practice can also contribute to the control or breaking transmission of COVID-19 through animal disease surveillance. So studies have highlighted the importance of monitoring virus circulation, not just in wildlife, but of course in domestic animals. In the context of human-animal-wildlife interface, you can see the incidence of Ebola. We can see the incidence of the current monkeypox that has also jumped the human-wildlife interface. So we need to do that to strengthen our preventive measures among local populations, because these are the people that have very close interaction, at that human life and wildlife interface. And we need to implement sentinel surveillance during human outbreaks of zoonotic disease, such as the COVID-19. We know that the human disease surveillance and human reporting has been really intense over the years and has attracted a large resource and commitment. On the other flip side is that the domestic animal disease surveillance is still suboptimal. Of course, the wild animal disease surveillance are either even non-existent or reserved for some of us within the academic for research purposes. So the pattern and the epidemiologic jump of this outbreak has reiterated the importance of effective participatory human and animal disease surveillance. So we can't continue to do an animal disease surveillance or human disease surveillance in isolation. So there has to be a participatory method of disease surveillance for us to really gain some mileage in diseases that have zoonotic potential. Because if you see, reciprocal transmission of SARS-CoV-2 between humans and animals can potentially create a wild animal reservoir of coronavirus. Thus, this would endanger the gains we have made in the control of this COVID-19 in humans because of the devastating disease in vulnerable animal populations. So it runs a full cycle. By the time we gain mileage in the human population, we might lose that mileage if we do not carry out a concise animal disease surveillance, because it will run a full cycle by coming back to the human circulation as well. So it is very important that scientists monitor the pets, the livestock, and the wildlife to work out where SARS-CoV-2 could hide and whether it could resurge. So how do we look at animal surveillance as a future preventive strategy for COVID-19? So the Nigerian health system has developed, we have standardized DSN as the disease surveillance notification guidelines and tools that, that is meant to allow early detection of disease outbreaks so that we can immediately institute control strategies for timely intervention. However, there are still challenges and barriers for this timely and effective reporting in the country. The recent surge in Lassa fever and yellow fever outbreaks in Nigeria offer new prospects at understanding the interaction between human and animal. Because as it is, we still have an isolated disease surveillance and notification system in the country. And that recent surge in some of these preventable Lassa fever and yellow fever outbreaks, and of course COVID-19, has continued to raise and bring our notice to the fact that we need to have an interaction between the human and the animal surveillance mechanism in the country. With SARS-CoV-2, we are continually having new variants that are evolving in animal hosts. This could have pandemic potential, and they can actually even escape the immunity that we think we have conferred with the existing human vaccines. On the long term, even, animal-based reservoirs of SARS-CoV-2 will increase the likelihood of disease resurgence, further undermining all our global disease control efforts. So what do we need to do? What are the future perspectives? We need to immediately carry out a desk review of our existing animal surveillance systems to assess our readiness for the system to predict and prevent the future outbreaks. We must be able to predict. So when Nigeria, our current policy on animal disease surveillance is operation and enforcement, we must look at those policies on our surveillance system, their operation, the enforcement, and even the regulation, because they're still unnoticeable. So we need to bring that notice, we need to bring that attention on the policies, that workable policies, especially in the terms of us strengthening our public health system. So we must institute a strong preparedness to COVID-19 and other future pandemics. We must be ready at all times to tackle head-on COVID-19 pandemic, because it is imperative that we review the scope, the operations, and the effectiveness of armed surveillance in the country, so that we can go towards having an integrated system, because most of these outbreaks are often reactive. We are not prepared. When it's here, we just carry out a rapid response activity, but we must have a predictive approach. If we are able to have an animal or a wildlife disease surveillance, at some point within our wildlife, we would be able to know that there are changes within the wildlife disease outlook for us to be able to predict if there would be an animal or a human outbreak in close times. So an extensive health system strengthening is not only to respond to pandemics, but to predict and respond to the future. And that brings me to One Health collaborative approach, which is a collaborative, multi-sectoral, and transdisciplinary approach. You can see I'm a doctor of veterinary medicine, I have a public health degree, I have a degree in epidemiology, I've worked across social scientists. So it has to be a multi-sectoral, transdisciplinary for us to be able to recognize the interconnectedness between people, animal, plants, and even our shared environment. Thankfully, the FAO, the WHO, and the OIE have a tripartite group that principally promotes the control of zoonotic disease through the One Health strategy. I would like to exemplify the One Health strategy by citing this historical example in 1893. A physician and a veterinary research team, and a physician and a veterinarian are members of the research team, Theodore Smith and Kilburn, that discovered that the cause of cattle fever, Babesia bigemina, was transmitted by an arthropod ticks. Their work helped to set the stage for the discovery by Walter Reed and his colleague of the transmission of yellow fever. So it is that collaborative relationship between the physician and the veterinarian that led for the future work that set the stage for yellow fever transmission. And we're able to then even discover a vaccine that is efficient against yellow fever. So my conclusion, although the risk of infection and serious illness has fallen drastically, we can see there's reduced transmission, reduced number of cases reported in Nigeria presently for fully vaccinated, because we've seen the efficacy of being fully vaccinated against COVID-19. However, the emergent and fast spreading variant, we had the Delta variants, pose a major threat to unvaccinated population, because this is a new virus that we know that even the knowledge about the virus is emerging as the disease is emerging. So that poses a huge risk to people that remain unvaccinated. And the knowledge of the potential role of animal species, such as bats and birds, in the transmission of coronavirus is of importance, So that brings on the emphasizing the importance of animal disease surveillance to understand the epidemiology of the disease and for us to institute an effective control measure. Finally, Nigeria should emulate the more developed countries like the Netherlands, the United States, the United Kingdom, by instituting an enhanced strategy for animal epidemic prevention and control in a One Health collaborative approach. I know Nigeria, we have gone better than we were. We now have, One Health initiatives, by ministers of health, animal, and the environment, where we are looking at how we can be more collaborative, but we have to really do much more for us to gain more mileage. So thank you very much. This is the references, and thank you for listening to me. I hope I didn't take 25 minutes. Sorry about that.
It's all right, Ma. Thank you very much, Dr. Nusirat Elelu. That was a wonderful presentation, I must say. So once again, I would like to thank the two panelists for the comprehensive presentation. So let's turn then to the questions for the panelists. Okay. Dr. Atilola, I hope you're still there. Hello? Is Dr. Atilola still with us? Yes, she's online. Okay, so maybe I take that for Dr. Nusirat while we are trying to get Dr. Atilola. So Dr. Nusirat, these questions from the audience, she said, is the percentage of vaccination population that you quoted, is it for the entire population or for target population?
Okay, do you want me to answer each and every one, or you want me to note it?
Yes, let's ask and you answer. So,
okay, so for the 23% of Nigerians, these about 25 million Nigerians that have taken the vaccine. This is a percentage of the eligible population. So currently, over 18 are the age that were initially, qualified to receive eligible population for COVID-19 vaccines. So for presently, we have also dropped it to 16 years of age. So this is a percentage of eligible population for us to achieve herd immunity.
Okay, thank you. I hope that answers our questions or his question. So I move on to the next question. So the question is, how is the gap between biomedical pathway, that is the epidemiology, and the local understanding of disease transmission, which is anthropology? How is that gap bridged during an emerging infectious disease like COVID-19 in northern Nigeria?
Okay.
How do you bridge the gap?
Yeah, thank you so much for that question. So by biomedical pathway, I want to believe you mean those of us in the medical pathway, epidemiology, and etc. So for us to make advances in One Health, we need to engage, especially those of us in the medical field. We need to engage those that will help us understand those connections, which are the anthropologists, these are the social scientists. We can actually gain mileage by that interaction in a One Health collaborative framework, by risk communication and community engagement. By risk communication, recall that we talked about people having disbelief in even the existence of the pathogen. And this not just for COVID-19, you would not believe that even for polio vaccines that have been over 40 years that we have been administering, we also still experience that hesitancy in use. So we have that strategy of involving anthropologists like social scientists strategy for prevention and control. So that will contribute, a culturally appropriate, locally specific, solutions to emerging health challenges. Because, these are people that are closer to the grassroots, and it will be a bottom-up approach, and of course, the community engagement component is also very important because we have to engage critical stakeholders. Like when I chaired the community engagement subcommittees, one of those things is people didn't understand why the government asked them to use face masks. So we had to do we had to engage the people to make them understand, to make them typically see the importance of wearing a face mask, and they were like, oh, I see. And they were amenable to utilizing these strategies. So it is very important that we have that, that bridge between the biomedical and the anthropological pathway, especially when we're tackling health challenges of this nature.
Okay, thank you very much, Dr. Elelu. So the next question is, what are the possible ways to generate data from animal disease surveillance program that will provide sufficient evidence in evaluating the national disease control and eradication strategy? Okay, so for surveillance, we have both the active and the passive surveillance. Either of these strategies must be combined for us to have a holistic strategy for effective control, because we need to do a routine or passive surveillance in our hospitals, in our laboratories, in abattoir, so that we can actually see and monitor trends, and that will provide a quality data that can be used for informed decision in healthcare implementation policy. You can also have the active surveillance, like the sentinel surveillance in a wildlife population, where animals that are susceptible or have history of being origins, like bats, can be active surveillance can be carried out amongst those populations, so that we can predict future outbreaks, and of course we can have data that can support the whatever intervention that we need to do, of course. So I think those two, if we are able to strengthen our active and passive surveillance, both in the human-animal wildlife interface, we would have enough data to support evidence-based policy making. That's right. Thank you very much, Dr. Elelu. So another question here is that, what is the possibility of the Nigerian government to get involved? I think during your speech, you tried to answer this to some extent. So the person says, what is the possibility of the Nigerian government to get involved in one health strategy that comprises of an intersectoral coordinated approach for effective surveillance, prevention, and control of zoonotic diseases in humans? Okay, so
Nigeria has also joined other West African countries, especially the ministers of health, ministers of animal health, ministers of environment, to bring up strategies, policy documents, initiatives in One Health model, because we know that there is this recent enlightenment about the need for us to collaborate due to 75% of pathogens emerging and re-emerging being of zoonotic origin. So we can't continue to treat animal or human diseases outbreak in isolation. So we have those initiatives that are put together for people to work together. And you can see that even at now we have the National Centers for Disease Control, the West Africa Centers for Disease Control. These are all One Health institutions that have been given those terms of reference to ensure that we work together for the betterment and for us to be able to prevent future pandemics, predict future pandemics, and of course handle existing ones.
Okay, and this is the last question now for you, Ma. So she said, the person said, those in rural areas still don't believe in COVID-19. Let's talk of prevention and vaccination. How do we solve this effectively?
Yes, I think you're asking the right person, because one of the things I do every day is community engagement and risk communication. So yes, like I always answer when I'm asked that question, like as much number of people that want the COVID-19 vaccine, we still have as much number of people that do not want. So we have, now what we do is to target those that are interested in the vaccine, take the vaccines to them. And for those not interested, what we do is to have active community engagements of stakeholders and influencers and people, they are going to be ready to listen to, like pastors, like imams, like we had similar problem even during the Ramadan, where people think that, oh no, if I take COVID-19 vaccine, my fast will be broken. So we had to engage the traditional ruler, the chief imams, and let them know that, oh look, vaccine does not break the Ramadan. You can actually take your COVID-19 vaccine. So we're going to continue our community engagement strategies. We're going to continue to engage people. And you and I will also work to see how we can make sure that we reduce the number of infodemics out there. We need to put the right information out there so people can believe in the efficiency of this public health intervention.
Okay, thank you. Though I have another question for you, but I quickly want to ask if Dr. Atilola is there so I can ask his own question. Dr. Atilola? Oh, I called you first. Is that right, sir? So there are some questions for you too. The first question for Dr. Atilola is, with increased prevalence of anxiety and depression experienced during COVID-19 pandemic, which you have also mentioned during your presentation, as well as post-traumatic stress disorder. So the question is, what are the immediate steps taken to increase mental health support?
Well, thank you very much. Like I said in my presentation, that the mental health response system in Nigeria, just like most other aspects of healthcare response system, is still very poor. One of the things that ordinarily countries use to address period when they have an upsurge in mental health problem is what I describe as those self-help strategies. There are different kind of non-specialist driven self-help strategies that people can use when they experience mild to moderate symptoms of anxiety and depression. And these are supposed to have been part of our public health education system. But in most part of Africa, I would say, public health is often seen from the physical health perspective more than the psychological health perspective. So what we can be talking about now is to engage in a public, on a massive public mental health literacy campaign, where in the different places where people aggregate, especially young people, like schools, universities, we can take public health campaign, focus on understanding the common mental health problems and the common strategies to address them. That is what we can be talking about now. The other strategies that people have talked, which is more curative, is to have telemental health programs, where some of these educational or public health literacy programs are put in the social media, as in they can be embedded within the social media framework. Short videos, short talks, and short presentations that can be integrated into the information gathering system for young people, so that they can, as they are searching their social media for entertainment, they can also get some public mental health information there. That might be another level, but everything still boils down to improving public mental health literacy, because mental health literacy is the foundational resource you need in maintaining good mental health. You must first understand your psyche before you can protect it. So that will be my response to that.
Okay. Thank you very much, Dr. Atilola. The second question here is that prior to the emergence of COVID-19 pandemic, it is postulated that mental health support was weakly integrated in social welfare, labor, and youth policies. Yes, you've answered some of these. So what possible integrated policies should be in place for mental health support to be in place to support mental health?
So what's that question is more of a statement of intent. I have undertook a policy review of documents relating. I have a publication on the school health program of Nigeria as to how much mental health component is there. I have a publication on the social welfare program of Nigeria, how much mental health component is actually there. The truth of the matter is that many of these policy documents make very scant reference to mental health. In fact, the few times when issues that have to do with mental health were mentioned, it was from the perspective of substance abuse, which is a minute part of the issues surrounding mental health. So if we are saying what should we be doing, I think the first thing we can say is that those things that are not there, one, they need to be there, and the ones that are currently there are mostly there on paper. One of the projects that people have embarked on, and we have found it to be beneficial in terms of mental health promotion in Nigeria as we speak, is the integration of mental health into primary care. So we have the primary care system, or the primary health care system, as it were, where people address the basic health needs. However, within this framework, integrating basic mental health interventions into this framework is one of the best ways, in my own view, that we can promote population mental health. If that is something that the country can embark upon, because there are already WHO recommended small packages of mental health training and mental health intervention packages that can easily be integrated into primary care, and it has been demonstrated to be integratable and of good impact. So it's for us to just implement some of this already established pathway without reinventing the wheel, as far as I'm concerned.
Thank you very much for the response. So I think I have just two questions here that we might probably be able to answer quickly because of time. So one for Dr. Atilola. The last one is, what is the current position of the use of virtual mental health services and psychosocial support to impart mental health education and communication resources?
There is currently a global consensus on the fact that mental health services can be delivered virtually. In fact, one of the advantages that mental health services has ahead of physical health services is that in mental health practice, we focus more on the psyche. In fact, that is one of the reasons why they describe one of the things that we do as talk therapy. So we want to talk, and the electronic platform provides such unique opportunity to talk without me having a physical contact with the patient. But unlike in physical health practice, where you want to do a complete abdominal examination, you want to check the chest, you want to do other form of examination that may not be possible virtually. What we need to do is to develop the virtual system, either in the form of telephony services or data-based, as in video enhanced kind of service, but to have a platform that people can go to, and there is somebody on the other end that is manning it. We have something similar to that in Lagos at one point during the COVID-19 crisis, where people can call in, talk about whatever psychosocial issue they are experiencing, and we can provide quick psychological services. These are things that can be expanded.
Okay, thank you so much, Dr. Atilola. That was quite straightforward. So the last question for Dr. Nusirat. So the person asks that If someone takes complete vaccine, can he or she move freely without observing safety measures?
Sorry. Okay, so I know that a lot of us are anxious to throw away our mask. And of course, party as hard as we could. If you have taken your COVID-19 vaccine, the Nigerian government has given clearance for you to go without mask in public places, right? In in outdoor, exterior, or if you are alone and all that. Or if you are in a closed environment, I would still advise that you keep your face mask on and observe social distancing until we're completely out of the woods.
Okay. Oh, sorry. I know there are so many questions there, but because of time, because we are running out of time, okay. We might not be able to take more questions because we are actually running out of time. We still have to give the vote of thanks. So I would like to say thank you to everyone that have attended this webinar, and I'll quickly call on Dr. Aziz Anjorin to give the vote of thanks on behalf of the Academy. Dr. Aziz.
Oh, thank you very much, Dr. Musirat. I want to, on behalf of the President of the Nigerian Young Academy, and likewise to thank the executives, to also thank the webinar committee, especially the chairman of the webinar committee. So permit me to thank the President and the executive for giving us the opportunity to be able to serve, and to specially appreciate our eminent speakers in persons of Dr. Atilola Olayinka and my very good sister, Dr. Nusirat Elelu, for giving us that opportunity. The invitations were forwarded to them, within a very short time, and notwithstanding, they were able to, respond without saying, it is not possible. So we appreciate them. We appreciate our very good brother, and of course, the great consultant from the Lagos University College of Medicine, who is also a fellow of the Nigerian Young Academy, in person of Dr. Olayinka Atilola, and of course, our very good sister, who happens to be the chairman or the chairperson of COVID-19 response in Kwara State. We thank you, we appreciate you. We also thank all the attendees for finding out time to be part of this webinar 3.5, and to also implore each and every one of us to be part of the subsequent ones that will be coming, after this timeout. We also appreciate our founder, that is the COVID-19, rapid response grant that was given to the Nigerian Young Academy. We appreciate all our members and of course the fellows. We thank you all. Enjoy the rest of your day. Back to you, moderator. Thank you.
Okay, thank you so much, Dr. Anjorin. That was a good one. So to this end, I think we have to draw the curtain, and we have come to the end of today's webinar series 3.5 from Nigeria Young Academy. Thank you once again to everyone. Thank you and thank you.